Good morning, everybody. Welcome to Grand Rounds, one of the early Grand Rounds in the springtime. So welcome. I'm very pleased to be able to introduce Dr. MLaposata, who is currently chair in the Department of Pathology at the University of Texas in Galveston. Dr. Laposata got his MD and PhD from Johns Hopkins. He then took a postdoc at Washington University, and at the same time he got his training in clinical pathology. He then took a job in Penn for a few years in the hemostasis lab. He then moved on to develop laboratory medicine at MGH, or Massachusetts General. MGH to me was the old Minneapolis General, but anyway. And after that, he moved on to be pathology in chief at Vanderbilt, and finally in 2014 he went where it was warm and is now in Galveston, Texas. I want to just say a couple things about his background. I'm not going to go into a lot of detail. He has over 180 peer-reviewed publications. His original basic science research was in the area of fatty acid metabolism, and clinically he works in the area of a lot of areas of clinical pathology, but in particular coagulation, and this is where he's really gotten to be known. Of interest, he's received a lot of awards, of course, but of interest, he did receive the Gerald Evans Award from Eclipse in 2004, and that's a connection, of course, with this institution. In the past, I have told our residents that they are physicians first and specialists, i.e. pathologists second. And Dr. Laposata epitomizes that concept better than just about anybody I know. I had the privilege of attending the second Diagnostic Management Team conference in Galveston in early February, and I learned a lot about diagnostic management teams, their value, and what they can add to patient care. So Dr. Laposata is going to tell us a little bit about diagnostic management teams. Mike?
Okay, thank you, John. Oops, I think it might be a little better with the microphone. Is that better? Good? Okay. Delighted to be here, I know many of you. I think this is where the progress occurs. It's in the room with Grand Rounds, with the people who have to adopt a new service. And I have to tell you that, for me, it's not new. In 1984, when I was a resident, I got a page from somebody who said, I have a patient with a prolonged PTT, and the person had no idea what to do with it. What factors should I order? What is a lupus anticoagulant? And it was March, and I said, you've been an intern since July, what you been doing? He said, what everybody else does. We guess. I said, you guess? I said, I bet you gave plasma. Realized from 81 to 84, 1 out of 20 bags had HIV or hepatitis C. You killed people. We made it necessary to get a liver transplant 10 years later. So I got the idea that anatomic pathology doesn't hand back a slide and say good luck, and radiology doesn't hand back an MRI and say, if you can't figure it out, give us a call. So how come we're doing this? How does that work? Can't we do it systematically? Everything that's complicated comes in and it goes out with something every doctor can understand. So I went to Penn, got my first job. I said, I can do this. This is the coag lab. So it was my coag lab. So I had the resident, we worked together, we hand wrote the notes, put them in the chart. It was a huge success. Everybody said, wow, for the first time I can understand why somebody's getting a clot, why they're bleeding, and where did it lead us? Well, the chief of hematology came and said, my fellows aren't getting any consults. He said, you're giving them the diagnosis too soon. And I said, doesn't the patient come first? And he said, after my fellows. Okay, I got the idea. And he was a full professor and I was a newbie. So it stopped. Then I went to the Mass General, moved up the ladder to Director of Clinical Labs, took it on, just did it. One Monday we said, that's it. I got a dictaphone. There was nothing special. We just said, we're interpreting all the coags. Everything that was more than a PTT came into that lab. Bring it at 5 o'clock with your best shot at it, resident on the surface. So they looked up 10 cases, which we had that day. They gave me some background. Remember, 26-year-old, boom, 10 reports. So it goes in really popular. Now there are 4 hematologists who know coag. One person comes in and says, I know this. I said, I know, there are 4 of you who know coag at the Mass General. The other 1,996 have no idea. And he said, you're taking money from me, and he rolled that thing up and he threw it at me and laughed. It was not a game for the faint of heart. We did it for a long time. And then the opportunity to go to Vanderbilt, one notch above, as pathologist in chief, was related to their interest in building more of them. So heme path emerged, besides coag, transfusion medicine, neuropathology, hyperaldosteronism. We built 5. Now the idea is in Texas, if we can unite the centers, the 6 major academic medical centers, we have an expert for everything. There is no reason not to have an expert at the bedside. You know how medicine is practiced. You and your loved ones get sick with life-threatening illnesses, and the person who takes care of you for that is the person who knows the most in the local environment. And if they don't know much, then too bad for you. And when heme and onc merged, everybody became an oncologist. So for my piece, who are the coagulation people? I trained them for 20 years at the Mass General. There was one person who didn't do onc. One. So there are no people. People are guessing in this field still and making lots of mistakes. So the idea of a diagnostic management team, which started in 1984 when I asked the chief of the coagulation laboratory, shouldn't we start this? And he said, I don't have time, I have to do my research. Now, what is it? So it's only 34 years later, but the external environment has changed because it just got ridiculous. I mean, now people say, I have hemophilia A. Oh, wow, that's a little part. Well, what are your mutations? Do you have an intron 22 inversion? Because if so, I can't give you factor 8. And by the way, now we're making factor 8, and we're attaching FC fragments or polyethylene glycol to increase its half-life. And you need different assays for all of them. The doctors are now willing to say, guess what, I have no clue. That was a big jump, because for a while it was just too embarrassing to say, I have no idea. Now everybody's raising their hands and saying, would you guys do it? And there was a sense of, if you don't do it in pathology, somebody else will do it. Guess what? Nobody's doing it if we don't. So let me tell you the story about the DMT. This is evolved. And I'm going to give you several parts to it. I have no disclosures. Come on. No. There you go.
Maybe with a key.
Okay. No? Okay.
Touch the touchpad for a second.
Yeah, it's been up there a long time.
Short talk. Really one slide. Okay. Are we going?
Yeah, we're going.
Will we go to the third slide? Okay.
That's right.
Okay. Okay, so we're going to talk about what a DMT is. This is what we've been doing, throwing test results over the wall. So here's the picture. This is us. And that's factor V Leiden heterozygous. Going to some doctor who has no idea. What is that? Do I anticoagulate for life? What's the risk for thrombosis? And notice the pieces are falling to the ground as they try to see patients. What we have to do is this, right? We actually have to pick up the puzzle pieces. Don't throw them over the wall. Let the treating doctor, as I like to call him or her, the treating doctor treat patients while we do this and put the puzzle together and say, by the way, here's your whole story. Yes, this is a leukemia. AML is 51 relevant mutations right now. These are the mutations, so likely you're going to get your chemotherapy choice and your prognosis out of this. And why not? Why not do it that way? So instead of saying positive or negative or 13.2, we're going to do something different. And here is what the data looked like for coagulation the day before we started coag rounds for the first time at Vanderbilt. I asked the chief medical officer, had been there 27 years, do you even know what these tests are? He said, are you kidding? And they have ridiculous abbreviations. I said, that's because they only give us 6 characters. What do you do with heparin-induced thrombocytopenia in 6 characters? Because if you put hep, they think it's hepatitis. So there's no way to do this. So he said, I have no idea. He said, I look for the asterisks. So there's one. And he said, I have no idea of the important negatives. And I said, you've been taking care of this for 27 years. How come you never asked? He said, who was I going to ask? He said, you know who's in the path department. Do you think there's anybody there that I could call up and say, just look at them all and write a paragraph? He said, impossible. He said, there's no receptor for me. I said, Alan, we're creating a receptor. And this is what happened the next day, July 1st, to that very same patient. We said the PTT's elevated, the PT's okay. They did a screening time for what's the thrombin time, not necessary. And we then picked the test. It was all algorithmically driven. So we did a PTT mixing study. It identified an inhibitor. We looked for the most common inhibitor. The Russell vapor venom time checks for the lupus anticoagulant. It was positive. That was the prolongation of the PTT, and it doesn't make you bleed. And he said, I understand it. Everybody understood it. It was written in language that you could get if you're involved in medicine. So a lot of people have said over the years, we do a DMT. So I realized that last year, for the first DMT meeting in Galveston, we needed a definition. Here is the definition, because a lot of case conferences are explained as DMTs. You have to have these 4 things. Number 1, you have to meet frequently. So you can't meet every 6 months and say, oh, we have a DMT. Second is you have to meet during the time when they're making treatment decisions. So if you've got a meeting and the factor VIII inhibitor has been diagnosed, the person's been treated with Novo-7, the bleeding has stopped, and now you're talking about it, it's not a DMT. When you see the Bethesda unit of 6, that's when you need to start talking. So you have to meet regularly enough to impact the decisions. Now we have a DMT on child abuse. So we have gotten about 30 people out of jail and reunited families because we know all about clotting. We brought medical examiners in. I got the clotting piece. We are figuring out why some kid with a subdural hematoma really had von Willebrand's disease was not beaten by his father and dad's gotten out of prison. So over and over again, we are doing these kinds of things. So there we can meet once a month. But for coag, we have to do it every day. So does it change your day? Absolutely. Is this a big obstacle? Ooh, of course, right? Because what you've been doing every day completely changes. It means that this is the first thing. It's patient care. This is what we do. And if we can't put that in, it's a problem. Okay, the third thing is you have to consider things in clinical context. The PTT is elevated. Okay, so what? So the PTT is elevated and the patient is not on heparin. The PTT has been elevated in the past. So you're writing a story of 4 or 5 sentences and you explain what's going on, and it has to go in the medical record. You can't take people through the micro lab and say, wow, look at that growing. Look at that, I've never seen one of those in cerebral spinal, and nobody writes anything. 6, 10 people are taking care of the patient. You don't write it in the chart. The only people who see it are the people who are coming with you. That doesn't work. So it has to be a note in the chart. So if you don't have all 4 of those, you're doing a case conference. It's not a DMT. Okay, so here's a true DMT. You put your arms around an area, and we'll talk about what that area might be. But you do all of them. You have a narrative interpretation. You discuss them. You optimize test selection. We're going to talk about DMT and how it helps with test selection, and you put it in the chart. So what else does the DMT do? We definitely, number 1, get a more rapid and a more accurate diagnosis. Because it's not just me. I would like to tell you, having signed up 50,000 cases, that I got them all. I mean, yes, I've seen Klansman's thrombosthenia, Bernard's, I've been involved in every kind of diagnosis in coag. And every day I go to coag rounds, I learn more. We got this incredible lady right now on the rotation, Gila Shining, woo! And she digs into these cases so deeply, I mean, I had no idea. And there's new knowledge about these things. So all the mutations that cause Lanzmann's thrombosthenia, I have a perspective about what it was 5 years ago. You know, Gila brought them up the other day. Now, I'm always current because some resident is bringing up the cases and we PubMed it, we Google it, we look at pictures. Everything is so educational. I get better as I do it. Now, so one of the things besides getting the right answer is we fix the problem of test utilization. So how does it do it? Here's what I'm going to talk about with utilization. How does the DMT impact that? Is a group of experts valuable to a treating doctor who doesn't know how to work up a PTT? Is it over or underutilization is the big problem? How much does over and how much does underutilization cost? So let's talk about this. So here it is, the clinical context and the diagnostic goals. You want to get the correct diagnosis right away, and you need to use all the necessary tests without using any extra. This is what everybody's been saying. This is what everybody's worried about. When Obama started talking about health care and made a few statements about the lab, what are you going to say? There's a problem with over-testing. People practice defensive medicine and they order too many lab tests. Okay, that's true. We do 30, 40% more complete blood counts than we should. So, is that the big problem? Or is the big problem that somebody comes in and they have a bleeding disorder and you never go straight for the problem? You know, a person who's a mechanic, I know nothing about the car. So I'm impressed by people who look at my car, say, turn it on, lift up the hood, and say, it's the carburetor. Really? I mean, that fast? That's what we need to do. I can do that with Coag. I can look up in the hood, in 5 minutes I got you the answer, most of the time. So what we gotta do is to not try to fix a car when we have no idea where the carburetor is. That is what's happening in medicine now. So I got to sit on the National Academy of Medicine panel, 21 of us, about diagnostic errors. We kill 64,000 people in American hospitals. You have asthma. No, you don't. You have a pulmonary embolism. While we're treating you for asthma, the clot got bigger and you died. Whose fault is that? That's a preventable error. It shouldn't happen. Bing, count it. So it turns out that underutilization is a bigger problem. This is underutilization, you're missing tests. This is overutilization. There's a big gray zone. I always hate it when CAP Today, for example, comes out and says hypercoagulable tests are unnecessary. Well, who says, right? Is it just, I wouldn't do that, right? It's so personalized. You want to be necessary, unnecessary, partially necessary. You do a half a hypercoag workup. It's all something we have to think about, but to make dramatic stuff, biopsies are no longer necessary. Okay, maybe for some people, maybe if you have a PSA of 4 and it's a prostate, maybe it's unnecessary. Okay, but not everything. So here's things people in Coag argue about. Do you need a factor 12? It doesn't make you bleed even if it's 0%. But if it's missing, it prolongs the PTT and people are going to get worked up over and over again. There's 8 different lupus anticoagulant tests. How many should we do? Are these really the same thing? Do we need them both? Most of the people who have factor 12 deficiency are of Jewish ancestry, so or 11 deficiency. So should we do it on anybody else and more and more? So people have said, how much does this all cost? So let's just take a look at this. And to sort out whether or not there's been a problem of over or underutilization, wouldn't it be great to take it case by case, as opposed to making broad statements? You look at the whole case. Somebody says, here's this 26-year-old lady, and she's had a stroke, and she did this. Is that over or underutilization? Well, we did. What we said is that as we review every case at Coag grounds, we are going to say, and we're only going to say over or underutilization if all of us agree. Me, another person who's a junior guy who does the coagulation lab, a senior hematologist, person in critical care, and 2 residents. So it's about 6 of us. And if all 6 of us don't agree it's over under, not counted. Of 200 cases early on after I moved to Texas, 155 had over underutilization. So is that a surprise? Guess what? Same number at the Mass General. Same number at the Mass General. So you say, oh, come on, really? Well, it turns out that There was a study published in the New England Journal that got a lot of attention that said only 55% of what should be done for heart attack, stroke, hip replacement, all the kind of common things gets done, and we skip 45%. While we're overutilizing on the same patient. So you got a stroke, and what we're going to do is complete blood counts every day. Irrelevant. So patients are over and underutilized. The same person is getting over and underutilized. So here's our study, which we just published in Diagnosis last year. Is this amazing, the consistency? Underutilization is bigger than over. So only 55% of us get what we need to get. So when you have orthopedic surgery, this is a big question. You get Coumadin? Is it aspirin now? Should we be giving you Lovenox? What is it? Rivaroxaban's now an oral drug? How long do you give it? 14 days, 28 days. Totally screwed up most of the time. So when people get a PE or a DVT after having their hip replaced, preventable problem most of the time. So the cost of overutilization. Let's take a look at the cheap test. If you just do a quick calculation, 25% of complete blood counts, and if it's 25,000 tests per year that are extra, and I was generous here, we'll call it $10 a test, that's $250,000 for a lab budget of $25 million. Fixing the CBC problem doesn't do much. Now, there is another target, and that is send-out tests. Because if you send out a total exome analysis, it's $5,000. So if you can stop 500 of those to not get done that are unnecessary, we'll say more about this in a minute, now you can save 10% of the lab budget. So if you were going to make a target, maybe that's it. University of Michigan has a formula. You can't have this. So really? So what we've learned is that underutilization is such a big problem that if you showed up on Monday and we did an expensive test and made the diagnosis on Tuesday, it's cheaper than not doing the diagnostic test and waiting till Friday, because you got 4 extra days of length of stay. And you have plenty of time to catch something from the person in the next bed. So, big problems. Now, this is an interesting piece. There's now a term called diagnostic odyssey. You don't know what you have. Okay, what are we going to do? Well, we can look at all 23,500 of your genes, so let's just do it. So this neonate thing showed up at Cornell, and somebody took this question, which I thought was crazy, and they said, we'll take the floppy babies, they can't talk, we don't know what they got, they could die in a few days, and we're going to do a total exome analysis. Oh boy. Well, they said we're only going to interrogate the information we have for about a couple of hundred things that a baby might have. They got a diagnosis on 40% of the kids, and half of them were saved. So here's something that would have been thought of as total overutilization. The Michigan people would have said, no, you can't have that. It's not on the formulary. You're not allowed. But now, the world has changed. So, what happens is you save money by doing a test like that. That's why you need experts. Does this make sense or not? So, the lab budget can go way up. Here's the conclusion about floppy baby. Who would have thought a total exome sequence to evaluate a floppy baby made any sense? And now it's almost standard of care. Our chief of pediatrics wants the good old days. Remember, Mike, when we did the blood tests? We did them all right here and we saw the answer. I said, yes, Joan, I do remember. I said, those tests were so bad you could have just flipped coins. Then maybe you got the right answer or not. And then she says, hey, Mike, we need exome analysis for floppy babies. Joan, you want an exome analysis? Do you even know what an exome is? Right? We need exome. So when I'm getting it from Joan, I know, okay, this is real. In her world, this is what they're talking about. So what was once considered overutilization may be a problem of underutilization. They need us. Right? So let's talk about under a bit. So at the committee, the National Academy of Medicine Committee on Diagnostic Error, we had to come up with a definition. Here's the definition of a diagnostic error. You showed up on Monday, you should have had the diagnosis on Tuesday, it took till Wednesday, Thursday, or Friday. It was a delayed diagnosis. Bing, we're counting that. Second is you showed up on Monday, we never figured out what it was, but you kind of got better, and on Friday we just said, don't know, but go home. Those are diagnostic errors. So that's the definition. So people have said, how much does underutilization cost? So I said, okay, we'll take one disease that I know really well, and you tell me how to calculate it. You have a clot right here, right here. You have a clot right here. So now what we're going to do is to say, what should we do to work up this person? So I came on a trip from Paris back home to Houston. I arrived on a Sunday, and on Monday my left leg was swollen. So this is a personal experience. So I go to the emergency room, and I said, my left leg is swollen, I could have a DVT. By that time, I'd already written my Eliquis prescription. I was taking no chances. And so this ER doc saw me, and she said, what do you want me to do? I said, I think you should do a D-dimer and a compression ultrasound. I said, well, it's not that swollen. I said, it doesn't matter. All I need is a piece this big to go off and go into my brain, and the right side of my body is not moving. So she said, I don't think we need a D-dimer if the clot is in the leg. I thought only in the lung. No, that is wrong. And then I listed the tests where I might have a risk factor, and she said, I never even heard of these tests. Hey, guess what? This is your hospital. So this is the way it works. This is American medicine. So I just told her, I did the whole thing, and said, here, do these tests. I looked at my own compression ultrasound. It was a ruptured Baker's cyst. When there was no clot in the popliteal, I said, okay, it hurts like crazy, but I don't have a clot. Okay, so if you don't talk to me, if you don't order the lab test, if you don't do the compression ultrasound, you save about $500. So what are the options for what could happen? So I'm an adult, I could have this going on. So there's the clot right here. It could just stay right where it is, and I could go home. It could give me a little pulmonary embolism, but what the heck, it didn't make me short of breath. So maybe it's a wash. It doesn't cost too much, and I saved $875 or so maybe it's even. But these are also options. One is it gets bigger. Now I have post-phlebitic syndrome. I'm in for $100,000 to $150,000 a year for a few years because I'm going to have to go back. My leg's going to be swollen. I'm going to need periods of anticoagulation. Or I have a PE that's big. Now I'm in that same zone. And maybe it's going to be $20,000, $30,000 for decades. Option 5 and 6 are worse if you are one of the 4 people, every row, or one of you has a patent foramen ovale, and one that can take a little piece of clot and let it go up to your brain for a small stroke or a big stroke. And if you're a big stroke and you are immobilized and people have to take care of you, it's a fortune. So for somebody who just says, I don't know what a D-dimer is and I'm not going to do that, you don't need a compression ultrasound. Here's what it costs. This is what it costs. So, of course, we have to consider the others too, and that is the clot kills you. You get a saddle pulmonary embolus, you infarct too much lung, you die. So I just did a quick calculation because I'm not a business person, and yes, we work closely with the business people, but let's just consider options 3, 4, and 5. I was thinking about a hospital like the MGH. There's one DVT in the ER every day. There's one DVT upstairs. If you add those up and say we're being conservative about this, $50,000 a year, we might have prevented it by recognizing it, treating it, anticoagulating correctly. Okay, that's $9 million. And option 6, well, that's for the big stroke. Add those, that's $15 million. Now, hospitals don't work on savings. You know why? Because they're speculative. See, I just took a conservative estimate. You know what hospitals think the most about? Revenue. That's why Anatomic Path works so well. Benign, malignant, the $100 bills are falling from the ceiling. My wife still wants me to be a dermatopathologist. We had dinner at the dermatopathologist's house. He has 3 homes, one for each kid. I said, really, Ramon? 3 homes, one for each kid? And those 4 boats? Yeah, there is 2. He said, really, you have to learn dermat. So obviously, this is a lot of money. I don't know the exact amount, but how much do you pay people at $200,000 or thereabouts to do these interpretations? If you save $1.5 million, that's 10% of this. You could hire about 7. So, we really have to target the underutilization as well as the overutilization, but the big money is in underutilization. The death things make your hospital look bad. So mortality scores, if they get bad, are going to make you look statistically worse than your peers. Now this slide is important, and it summarizes what we just said. So somebody you thought had asthma, you came in and you had a pulmonary embolism. So you got your diagnosis 3 days late, and that kept you in the hospital for too long, tens of thousands of dollars wasted. You came into the hospital, you didn't get a diagnosis for 5 days, and you got MRSA from the person next door. Or your clot got bigger. Now, hundreds of thousands, and if there's no delay in diagnosis and you didn't increase the length of stay, you got the right test, hundreds. So this is really it, but we got this problem that it's hard to count, because in one institution, those 8 possibilities are all about the same. In others, really the first 2 are most common. They see small DVTs. In this case, might be a standard institution. It's a really hard thing to do. We're doing a big study. The CDC came to both DMT conferences, and they said, we're going to do a one-of-a-kind study. I said, really? They said, American health is on the line. You guys bring experts to every bedside. We are going to do this definitive study. We'll see what happens, but they're going to muster resources to let us do it. So, here's a problem for us in pathology, and it's which budget is being affected. And if you are an administrator and you do not know human suffering, you do not know what a pulmonary embolism is or asthma and how to treat it and what the clinical consequences are, but you manage operations, no negative impact directed at people who don't. It's just that if you don't have that, you must concede to the people who do. So, your budget is going up because you just did a total Excel analysis. Well, you must be a bad manager, because last year you had a budget of $16 million, and this year we spent $20 million on lab tests. You know what we did though? We got faster and more accurate diagnoses, and the general ledger of the hospital is now lower. And maybe it's lower by $50 million, right? Our budget went up $1 million, and yours went down $50 million, but it's hard to see it, because at the MGH, the total operational budget when I was there was $4 billion. $4 billion minus $50 million is a fraction. But in terms of absolute dollars, you spent $1 million to save $50 million. Somebody has to understand. If I can understand it, no business school, right? It's not hard to appreciate. So the problem is that 95% of hospitals in America are run by people who have never had any experience in medicine. 95%. The number of administrators since 1970 has gone up 3,000%. The number of doctors has gone up 50%. So just realize that what we've done is we've created a partnership that is challenged. And in the National Academy of Medicine meeting, we talked about how important it is that we make a partnership and make it work. So we did a little bit of study on this when I was at Vanderbilt. Larry Van Horn was from the business school. He said, look, I'll come in and I'll be really objective because I have no idea what all the initials stand for. And what we're going to do is we're going to do a DRG comparison before and after coagulation. And we'll do it right after. And so the total charges is on the x-axis. LOS is length of stay over here. And the red dots are what happened for patients with a pulmonary embolism, this DRG code. And the red dots represent before coag Notice really expensive, right? And notice the green right after coag just for 6 months after, is coalescing. And by the time we did it longer, the green dots coalesce further in the corner. Shorter length of stay, less money. Look what happened to intracranial hemorrhage. Same thing. We coalesced it, we made it cheaper, we got the answer right away. This is the impact of the diagnostic team. And people call up. So we're, yes, signing out cases, but you know what else happened? They knew where we were. And they came at 4:15 every day and went to 4605E, and people were confused said, I have a case. And we would stop and say, tell us about the case. And we were good enough that it didn't take 2 hours. Because of what we knew, we said, get that test, do this, and they got a diagnosis. So it really made a difference. Why hasn't it happened? The big question, right? For 20 years, I told you at the beginning, 1984. Why did it take that long? Here you go. So how is it that just a few people have said, I'm making the diagnosis the first thing that I have to do, and this is especially important when things have gotten so complicated lately. So here's the first problem. There are not enough experts. Yes, we're in a room. That's why I say this room is so important. We're in a room with potential experts, but we're not doing it. So what are the drivers to not doing it? Let's take a look. So here is number one. How much do you get paid for doing this? You know, if I go down to the emergency department, say, whoa, that guy's losing a unit an hour through a chest tube. Here's why. Do these tests. Don't give the platelets. $25. That's what I get. 25 bucks. And if I could bill it through a comprehensive clinical consultation, maybe 75. You realize that derm consult is way higher, and that's according to Marty Mim, my good friend at Harvard, most of them about 30 seconds. So this is backwards, right? So the reality is, I got this out of a paper in Archives this year. Most pathologists entering the workforce owe at least $140,000. Plenty owe more. And everybody says, wow, you're a power couple. You married one of your classmates. Yeah, but you might have each borrowed $250,000. Now you're $500,000. So maybe it would have been better to marry somebody who works in a phone company. So it's a lot of money. So virtually all pathologists don't do this. I mean, who would if you had that amount of debt? Maybe you should go do primary care pediatrics and make $85,000 and get woken up 5 times a night, right? That's great if you really love it. But how are you going to pay that off either? So it is an issue. The other thing is that we go out of town and somebody still has to do rounds. So we have 2 people. So I'm here, but Chad Oates is doing rounds. So we have 2 people. So you can't have a rounds that just stop. We can't do frozens today. I'm sorry. Our one pathologist is gone. Take off the entire breast. Just pull it, take the whole bone and pull it out. You can't do margins. That's it. So you can't have a service like that. So you need a better plan. So number one is partner, right? What I have said is that communications people, is Joe here? There you are, Joe. So what we need is, we need you guys to be able to do rounds at our place. And so if you have experts, we want you to do it. And guess what? We'll do some of yours. Our residents would be delighted to hear your presentations for co-ed rounds. And really, we're getting better at all the visualization. We've had 4 or 5 people come in. One guy's got Google glasses. Put these on, doc. I write. Everybody sees this. They see what I'm writing on the board. We're going to get this year. Some communication that is seamless, that makes it feel like you're in our conference room in Galveston and we are here in Minnesota. And that's what it's going to take. Because somehow we're going to have to break the cycle of, we don't have enough people. We'll be great for you for co-ed, but we can't help you for autoimmunity. We can't help you for anemia and the cause. So we'll give you iron for years when you have beta thalassemia. Come on. Why are we settling for that? And the experts, MD, DO, or non-MD, meaning PhD, or the new degree, Doctorate in Clinical Laboratory Sciences, which is the medical technologist, clinical lab sciences, who's getting a doctoral degree. We have a program at UTMB, and we're graduating 7 students in a year. And so we have to find people, and we are going to find them, and from one place or another, whether they're pathologists, PhDs, or non-MDs. You know, part of the reason why people say, and I'll get to this in a minute, is they say you only pay the MDs. So if we're relying on health insurance to figure this out, they can't. They can't figure out the same. Oh, you know, you came up with that thing for DVT. That's one disease out of thousands. We're talking about what? Millions, tens of millions? Think about that for a minute. But they can't sort that out. They think we're making up the whole thing. It's only revenue. The whole health insurance thing is all based upon how much you're earning and not how much you're saving. At Vanderbilt, they got it, which is why we built 5 DMTs right away. The president said it's all Vanderbilt's money. I'd rather save $5 million than earn 5,000. And I trust it. So you guys are off an order of magnitude, right? So you only saved $500,000, but it cost me a whole lot less. I'm still interested. So it has to take people at the top. The guy at the MGH really pushed us forward. He was an undersecretary in Health and Human Services during the Johnson administration. And he said, Mike, you didn't even have to write a paper on this. Let me see. You bring an expert to the bedside, and over here, there's no expert at the bedside. Who's going to do better? Okay, I think I have the answer without you writing a paper. So make more of them. Okay, so second problem. They decided, the health insurance companies, that it's insignificant, the payment, and we're only going to pay MDs. So the reality is that if you don't know medicine, then maybe it's hard to explain all those savings things and have somebody say, okay, I get it. So we don't pay people to save millions. Somebody comes in. You know who we pay people to save millions? Consultants. Right? And I know because I have plenty of good friends who are consultants. And they say, you know what? I just use a bunch of statistics. How many people are in that hospital every day? Okay, the statistics say you need 3.7 pathologists. Really? He said, do you know anything about what pathologists do? Not really. But, you know, I'm kind of learning as I go along. You're earning at their dime. I mean, they're paying a fortune. So really, it's a big difference. So this is totally unfair. Allison Woodworth, who's a PhD chemist, was at Vanderbilt. I went to Allison and said, we need a DMT, and I'll tell you why. Because I want to take a movie of your DMT and my DMT, and then I want to show them one after the other, and then ask the question is, why does that guy get paid and she doesn't? Because it's not fair. You looked at the medical record, you sorted it out, doggone it, you need money. You deserve money, and the AACC, Fred, has been reluctant to jump on this. They're a little bit afraid. Maybe this is dangerous and we'll get into some argument. The reality is it's deserved. How many MD toxicologists are there in the United States? A handful. So you need to pay the people who have non-MD degrees. They've done it in psychiatry and psychology, right? So you go to somebody, nobody says, oh, that's the psychologist, so we're not paying. Only the psychiatrist gets paid. We work in a discipline where we have a close partnership like this with MDs and PhDs. So some people will say, because you're not paying me, I'm not doing it. I went to Holland, where of course it's all government paid, so you don't have to deal with the insurance companies. It's not a big deal. So the solution is we have to get paid. It has to be a fair payment. We have to pay all the people who do the work. That will take a change. The third thing is liability. People get sued in America. It's a fact of life. I think you just have to realize somebody comes after somebody all the time. So you're going to have to explain what you know, why you came to your conclusions. How about this one? This is the biggest one. This is that culture change thing. How do we make you do it? How do we make people say, it's Monday, I have to look at all the cases that I put my arms around and make a report? So I've done a lot of surveys about people. Here it is. Why is it that they don't do a DMT? There's a guy named Richard Horowitz, who was in Southern California, who wrote an editorial shortly before he died about chemistry. And he wrote this: clinical chemistry isn't very alluring. And he said, what has to happen is you got to get the chemist to do a DMT on what they do. Pick it, toxicology, adrenal hormones, pick thyroid in pregnancy. But doggone it, do something you know really well. And it doesn't have to be every case. It can be the ones that are the most serious. But whatever it is, there's got to be a something. So here are the reasons. I don't like making a final diagnosis. I'm not sure what is echocardiography for and what are the details. And I'm not sure about compression ultrasound. And so if it was not in your training program, you say, I have too many holes. The reality is we're training these doctorates in clinical lab sciences. We have a course. I call it the Fill in the Holes course. But that's exactly what we do. It's a half an hour on what you need to know about echocardiography to understand about a diagnosis of an MI or a valve problem. What you need to know about EKGs, what you can pick your areas. So we are filling in the blanks. The doctorate in clinical lab sciences degree is like the Pharm.D. We didn't have doctoral level people in the pharmacy. They handed out whatever medicine you want. Want that? Yeah. The INR is 99. You want some more coming? Okay. So nobody ever asked the question. Then we got people at the doctoral level, and boom, suddenly it changed. So that was the origin of this, which started around 2000. There's one graduate wandering around who's getting a degree from Rutgers sometime, and then there's 7 from UTMB, and there are about 5 programs coming. We need DMT leaders who are willing to get past these barriers. I'm willing to accept call on nights and weekends. I could lose a court case. I'm doing research. You're not paying me anyhow. Who's going to fill in when I'm out of town? I want to see a DMT process. Come to the meeting. Visit us. As a generalist, I can't know everything. Neither can I. And by the way, I did this so I didn't have to see patients. So there it is. A major problem is that there's uncertainty, but let me just give you information about what I knew. Right? So I did residency at WashU right after Fred, and I did all my basic rotations, and then the second year I did coag rounds once a week, and I presented a case or 2 once a week. So I probably saw 100 cases when I took my first job. 100. Remember, I'm at 50,000 plus. So what the heck did I know? I mean, yeah, people said, oh, that's a factor VIII inhibitor. Okay, that was my experience of 1. But I knew more than most people, right? And then the coag rounds taught me something else. Whoa, that's 1 with irregular kinetic. So the fact is, you got to jump in. And so the perception of who could lead it, the people who have the DCLS degree said they could do a DMT in the morning and a DMT in the afternoon, because this is part of their training. Now they're coming in for the second year, and they have to show one. One of them says, I want to do an anemia DMT. I said, I need that. Because we have too many people who don't get a cause for their anemia and are mistreated for decades. So I said, Julie, you can do that. So now the question is, how many of these people can we hire? And we're talking now, talk to the dean and the president about bringing 2 or 3 people on board. What's the difference? I want the people who lead the DMTs. They're affecting utilization. They're affecting the rapidity of the diagnosis. So I think we can do a great job taking people who have doctoral degrees that aren't medical degrees, and they can be experts. So here's the solution. Take whatever you feel you know the best and start it for that group of patients. I asked Allison Woodworth, can you do thyroid? She said no. I said, can you do thyroid in pregnancy, because that's confusing. She said maybe. She picked up hyperaldosteronism. I said, okay, that's good. That's what you know the most. Toxicology for pain management instead of absolutely everything. So you can put your arms around something, but start. And the reality is, I know this is a hard message, you can start on Monday, right? You can actually get a dictaphone and start on Monday. That's what we did at the MGH, and the barrier is only really just, can I find the time, and am I emotionally ready to do this? So, what about anatomic path? Well, this is an interesting thing, because anatomic path has really changed. Well, what's the motivation? If you practice in the community, your expectation is provide the answer for what you see through the microscope. Does somebody expect you to say, here's everything, flow, and I know you may do it, aside from me. But it is not common practice to put all the pieces together. Here's your cytogenetics, here's your flow, here's your molecular, here's your histopathology. Please put all the inputs together and figure it out. So when I went to Vanderbilt, there was a group of 3 people who said, we're going to make a combined report. And so what happens now is we're into this zone. Microscopic review, some genetic testing. Do I think it's going to get to this? Absolutely. Do I really think there will be a machine that can pick up a cluster of 10 cells, and those are the tumor cells, and they're going to be better than our eyes? Absolutely. And if we don't want to admit that, we're silly. In 1972, I went to the community hospital in my hometown, Johnstown, Pennsylvania, and I saw a glucose assay. And the lady was mouth pipetting reagents. She made a standard curve, plotted it on a piece of graph paper, and I said, do you think a machine could ever do this? And she laughed at me. And then she said, of course not. And the next year, I went back to that lab, and they had an SMA. And they did 12 tests, and they were all automated. I said, Carol, what's that machine do? She said, well, it does a glucose and 11 other tests. And I thought, oh boy. And you had no idea it was coming? Yes. So it is going to happen. What is it that makes us indispensable then? It's putting all the data together. This is even tougher than artificial intelligence. You look at somebody, you get inputs from that person, and that person, and that person. A lot of it is so subjective. To get the right diagnosis is hard. So what we have done is we're using this technology, and now we have anatomic path sessions. The radiologist is on the screen. The pathologist is on the screen who looked at your prostate biopsy. The patient is on the screen, and the urologist is on the screen, and everybody's talking to each other. It's remarkable. In 5 minutes, the patient makes 4 doctor visits and can talk to the person, us, who actually give a diagnosis. I am now working closely with the chairman of radiology. I said, Eric, you do a good job. You find a bump. All right. I said, that narrows it down to about 135 things. I said, we actually tell you what it is. So the reality is we have to be involved in this, but we need to know that we biopsied the right part of the prostate. And there it is, and the needle went in here. And so you got to work together. Now, I want to tell you, as we get to the end here, about a couple other things. One is, we had a friend who died, and he was told this. I wrote this editorial, a new kind of autopsy. So he dies, and he had coronary artery disease. He saw the cardiologist and said, we're going to do a bypass. You probably have a few months to figure this out. He died the next day. And he was our administrator's husband. And so when this happened to Leland, his wife said, I don't want an autopsy. And okay, the medical examiner says we knew he had coronary artery disease. And so I said, was Leland taking aspirin and Plavix? Because he had a stent. And I realized that if you were just a general pathologist doing an autopsy, you probably weren't asking these questions. Now, it turns out that there's this couple of months. It turns out 15% of people who take Plavix don't respond to Plavix. So when you have 15% of people who need to take one of the other 2 drugs that does the same thing, a little more expensive, but if you are one of those people, you need to go to those medicines or you're going to have a heart attack and die because your stent is going to thrombose. I said, do we ever get pharmacogenomics for CYP2C19? Never done. Okay. So then I realized that the questions we were asking were the ones that are going to make us better. This is what the autopsy is supposed to do. What are our shortcomings? How can we take care of patients better and prevent this kind of thing? So the autopsy was done incisionless at Coag rounds. We asked all the questions about platelet function. Is antiplatelet medication? We knew the latest. It's the journals we read. And we said to the person who runs the autopsy service, Judy, what would have happened? She said we would have taken the heart out and found the clot in the stent. That's not to say all autopsy is superfluous. It's important. But I will say that if you don't bring a case like this to a group of experts, you won't get the right questions and you won't improve, which was one of the things the National Academy of Medicine committee said you must do. You've got to have autopsies. And I also wanted a little piece of tissue, maybe from his liver, for some molecular studies, just in case, because there's a bunch of kids and grandkids. So this was not the focal point of the traditional autopsy. The ideal, of course, would be to do both, but we did the autopsy the next day. He died on Monday, we did it, and then it was in our records. And now we review all the death cases that are related to Coag. Every MI, every stroke, every DVT, they all come to us. So now our mortality statistics by the Vizient data system, this is a ranking system, we went from 51st in the country to 2nd. We're finding the answers to what happened to people because we're not asking people of general knowledge. So we asked Heather Stevenson, if it's got something to do with the liver, what the heck is this? Can you do it at your DMT for liver? Because we have one for liver. Liver, child abuse, transfusion medicine, Coag, and microbiology is where we are. So the DMT would, DMA, Diagnostic and Management Autopsy, would involve an expert-driven review. So we wrote this editorial, and we think it should accompany virtually every death. Now, this is a summary to show you where we are. Give me a little license here. I like the history of medicine. We had a course in it when I was at Hopkins, a medical student, pre-1940. These are the diagnostic specialties. Boy, the people at Hopkins, Arnold Rich, he was the guy who looked at all these cases. What is sickle cell anemia? What does it do to the spleen? Paper. Here's what all the organs look like in sickle cell anemia. It was a lot of autopsy. And when you talk to Bob Scully, who was the editor for the CPCs in the New England Journal, really surgical pathology is missing here. Clinical pathology is we had a few scattered lab tests. Radiology had a few x-rays. That's prior to 1940. So what happened? The treating physician who examined you had to come up with a diagnosis, contribution to correct diagnosis. Here's what diagnostic people did, a little, from service management. Now we get to this big zone of 1940 to 1980, which I've lived in the end of this period and worked. So what happened in radiology is up to 1980 is they didn't have a CAT scan. And when I was doing my medicine rotation, I was looking at a film with my resident, and I said, shouldn't we ask the radiologist? He said, those people don't have a job. I said, what do you mean? He said, we call them up like 1 out of every 100 cases, and we say, what do you think of this film, right? But 99% of the time, they're just sitting there waiting for us to ask the question. I said, what do? They buy film. That's it. They buy film and hire the techs. Really? That's what a radiologist does? Yeah. In 1980, the CAT scan came. Then everybody said, where's the radiologist? Then the MRI came. Where's the radiologist? It changed, and they said, this is my job. My job is to interpret every single one of these. And I'm doing it without you asking, and these insurance companies are going to pay me for it, but I'm going to do it first and prove it. In anatomic path, we grew surge path and cytopath. The autopsy starts going down. Now, clinical pathology got scads of new tests. And what we decided is we're not going to deal with the diagnosis and sorting through the clinical record. We are going to build the laboratories and get you a right answer, which sounds pretty good. George Lundberg said it was the critical mistake in pathology, editor of JAM 26 years ago. He said, you guys didn't go clinical. They went clinical in 1980, you went managerial. When I took my job at the Mass General in 1989, people said, what is that job? Director of Clinical Labs. I thought it was just like a box with a machine. And you just put tubes through a window and they got all done. And I said, no, they're actually people who have to consult. I said, well, nobody's doing that for me. Yeah, that's about right. So where are we about that time? The doctors are still palpating kidneys, right? And we're helping a little bit more. From 1980 to 2004, radiology jumped in. Everybody wants a radiology residency. Good lifestyle, you make a fortune, pay off those loans. Anatomic path, growing, autopsy, down to a few, and clinical path, up to about 2004, now the doctors are getting to the point where it's bad. They don't know what they don't know. They think they got it. Oh, I know how to do that. No, you don't. You're doing the wrong test. And they answered questions when asked. This is us. So did we have a little bit more impact on the diagnostic side? Growth from better radiology and AP, more immunohistochemistry, getting better, right? Now, it's now. And this is radiology. They're bigger, stable. But now what we have to do is we got to sort out utilization. We got to take care of the cost and quality of care. And the National Academy of Medicine report says tens of thousands die. This is a labile top. And what has to happen now is that we have to automatically provide interpretations for complex things. There's a lot of tests. We got to fix the utilization thing. And when this happens, then what's going to look like optimizing everything is this. That's what has to happen. We are the diagnostic people. So on the correct diagnosis, we have to be the main player. We have the lab. This is where all the tests are done. This is laboratory medicine. This is surge path. This is radiology. Now we're talking about how good is the doctor palpating a kidney, pushing on a knee. That's useless compared to what we have, right? And they got to be the treating doctors, and they got to be really good at that. That is the way it's supposed to look. So the DMT, important for getting the right diagnosis, fixing over and underutilization, looking at causes of death, and in the last slide, here it is. You're a patient. Your most loved relative is a patient. And you could have the closest person around them provide a diagnosis, non-experts, faced with hundreds of tests. Or you could have a DMT and somebody could say in 5 minutes, that's what to do. And here's all the evidence. Who would pick having a non-expert? Who would pick? And yet it's all available to us, but we have to get organized to do it. And guess what? It's our job. This is us. We run the diagnostic services. So we can say, let's just do it until I turn 65, and then it's all over. Or we can say, you know, it's now. And let me tell you, I've seen medicine change. So if you were one of the residents here, you're in a transition zone. You're in one of these zones where everything's going to change. We tell our residents that what you are learning has to be more than recognizing what the image is on a glass slide, because that's going to be a small part of what you do. So you have to figure out how to put all the data together. That's what you're going to be asked to do. Thank you very much.
Probably take one question. We've got a session with the residents at about 9:15. So one question. Who's got the most burning question? Leo?
Sure, I go.
I figured you would.
So actually, I've mentioned this to you in the past. As all the pressure on healthcare costs keep inexorably going forward.
Yeah.
Based on what you showed, I've thought in the future, you're not going to have primary care physicians. You're going to have nurses or lower
And we're doing more of that.
lower
Yeah.
education, whatever. Not impugning anybody, but you're basically just getting a history and doing a physical.
Right.
And then working with, like you're suggesting, clinical pathologists, you get the answer and then you have treaters,
Correct.
whoever the treaters are.
So that's perfectly plausible. You see a nurse, practitioner, a physician's assistant, they say this is a coag problem, go straight to the coag person. Why are we spending all the time? Could that be done by a PCP? Yes. There's an immense amount of pressure, they're paid less. Could it all go away? That's been through the New England Journal about what are we doing. So I think that's quite plausible, but it is going to change. We can't spend $2.2 trillion on healthcare, and according to all estimates, waste $800 billion. 800 billion waste. The NIH budget is $35 billion. We could double, triple, quadruple the NIH budget. Joe Biden wants brain tumors to go away because his son died of a brain tumor. Then don't fund 3 grants in that section where they study glioma. Fund 30. And to do that, all you have to do is stop the waste. And then we have to take this money, put it to the NIH. So I think that what we're doing, yes, we're pushing our one domino, but the domino that we push is going to make hundreds of dominoes fall.
Tony?
So that was a fantastic talk, Mike, as always. The model I look at for a field that has really transformed itself is pharmacy.
Yeah.
15 or 20 years ago,
Yeah.
pharmacy was prescription in, pill out. Not unlike where we've been recently in lab, where you send in sample, result
Yeah.
out kind of thing. Today, the PharmDs are on the wards. They're
Yeah.
consulting on every,
Exactly.
not every, but most patients about the right drug, the interactions, the dosing, how long the patient needs to be on this drug. They've totally changed their field.
So that's what we got to do. It's exactly what's done. Well, thank you all for
Thank you.